Dr. Grant Ralston here for Strength Physiology Online with a lecture looking at diabetes. So we're going to look at type 1 and type 2 diabetes and look at developing your understanding towards this chronic metabolic condition. So the objectives of this presentation, you should be able to demonstrate understanding towards the role the liver and the pancreas has with regulation, the biological mechanisms of type 1 and type 2 diabetes mellitus, normal and abnormal blood glucose responses, looking at the various complications of diabetes mellitus, and the pharmaceutical interventions for type 1 and type 2 diabetes mellitus when we're looking at controlling the condition. But before we get started, what we're going to do is we're going to have an overview about the role the liver plays as well as the pancreas. So the liver is an organ only found in the vertebrates, and one of the central roles of it detoxifies various metabolites. It also aids in the synthesis of proteins and produces biochemicals that are necessary for digestion and growth. So in our cells in humans, it is located in the right upper quadrant of the abdominal, as you can see in this slide. The liver is large and it's a meaty organ that sits on the right side of the belly, and it weighs approximately 1.5 kilos or about 3 pounds. And the liver is actually reddish brown in colour and feels rubbery to the touch. Now normally you can't feel the liver because it's protected by the thoracic cage or the rib cage. And the liver has two large sections, and it's called the right and the left lobes. The gallbladder sits underneath the liver and along with parts of the pancreas and the intestines, and the liver and these organs work together to digest, absorb and process foods. One of the liver's main jobs is to filter the blood coming from the digestive tract before passing it to the rest of the body, and the liver also detoxifies chemicals and metabolizes drugs. And as it does so, the liver secretes bile that ends up back into the intestines. And the liver also makes proteins important for blood clotting and other functions. Working with the liver is the pancreas. And the pancreas is an organ located in the abdomen. It plays an essential role in converting the food we eat into fuel for the body cells. And the pancreas has two primary functions, as an exocrine function that helps in digestion and an endocrine function that regulates blood sugar. Now, when we're looking at the location of the pancreas, it's located behind the stomach on the upper left abdomen, and it is located by and surrounded by other organs including the small intestines, liver and spleen. It's spongy and about 6 to 10 inches long, and it's shaped like a flat pear or a fish extended horizontally across the abs. So the wide part is sometimes referred to as the head of the pancreas, and its positions towards the centre of the abdomen. And the head of the pancreas is located at the juncture where the stomach meets the first part of the small intestine. And this is where the stomach empties partially digested food into the intestine, and the pancreas releases digestive enzymes into these contents. So the central section of the pancreas is called the neck or the body, and the thin end is called the tail and extends to the left side. So as I said, the function of the pancreas, well, a healthy pancreas produces the correct chemicals and the correct quantities at the correct time to help with the digestion of the food that we consume. When we look at the exocrine function of the pancreas, it contains glands that produce key enzymes important for us to help with digestion. And these enzymes include trypsin and chymotrypsin to digest proteins. and then we've also got the carbohydrate digestion with the form of amylase and lipase to break down the fats. When food enters into the stomach, the pancreatic juices are released into a system of ducts that culminate in the main pancreatic duct. And the pancreatic duct joins the common bile duct to form the ampulla of Vata, which is located at the first portion of the small intestines called the duodenum. And the common bile duct originates in the liver and the gallbladder and produces another important digestive juice called bile. And the pancreatic juices in the bile that are released into the duodenum help the body to digest fats, carbs and proteins. As I said, another function of the pancreas is the role it has with endocrine function. And this is where it's important when we're starting to discuss diabetes. The endocrine component of the pancreas consists of the islet cells, or the islets of Langerhans, that create and release important hormones directly into the bloodstream. And two of the main pancreatic hormones are insulin, which acts to lower blood sugar, and glucagon, which acts to raise blood sugar. And it's important that the body maintains proper blood sugar levels as a key to ensuring that functioning of all these organs, including the brain, liver and the kidneys. So you may ask yourself, well, how is it actually regulated? So the human body wants blood glucose, or blood sugar, maintained in a very narrow range. And insulin and glucagon are the hormones which makes this possible. Both insulin and glucagon are secreted from the pancreas, and they're referred to as the pancreatic endocrine hormones. So what we see the picture on the left, it shows the intimate relationship both insulin and glucagon have to each other. And note that the pancreas serves as the central player in this scheme. It is a production of insulin and glucagon by the pancreas which ultimately determines if a client has diabetes, hypoglycemia, or some other sugar problem. So when we're looking at carbohydrate metabolism and blood glucose control, glucose, being carbohydrate as a raw ingredient, is the body's preferred source of fuel for energy transformation. And what happens is insulin and glucagon act to regulate this, to make sure that the blood sugar levels is constant within this minimum range. So in addition to the primary function, insulin also has a pronounced effect upon the formation of triglycerides in adipose tissue. It actually inhibits lipolysis and promotes glucogenesis and glycolysis. So therefore, the net effect of insulin is to shift the body's metabolism away from fat and towards carbs, or carbohydrates. So this breakdown of glycogen to glucose is known as glycogenolysis. So glucogenolysis. And it is important to note that glucose cannot exit the muscle cell into the blood to stabilize blood glucose levels, as it lacks the necessary enzymes. So in addition to insulin and glucagon, there are other hormones that play an important role in maintaining homeostatic control and blood sugar levels. And in particular, adrenaline, or epinephrine, cortisol, and human growth hormones. So adrenaline is produced by the adrenal glands, and that acts directly on the liver to increase glucose production via the process of glycogenolysis. And the opposing part of it, we've got cortisol. This is a steroid hormone. Like adrenaline, is secreted from the adrenal glands, and one of its primary functions is to make fat and muscle cells resistant to insulin and the actions of it, and enhance the production of glucose from the liver. So there, under normal physiological conditions, cortisol counterbalances the action of insulin. And lastly, human growth hormones. is released from the pituitary gland in the brain, and that's also similar to cortisol. So human growth hormone counterbalances the effect of insulin on the fat and the muscle cells. So you may actually ask yourself, how does insulin and glucagon work together? So these hormones help regulate the levels of blood glucose or sugar. So glucose, which comes from the food that we eat, then it's eventually digested and moves through your bloodstream to help fuel your body and your body's cells. Insulin and glucagon work together to balance your sugar levels or blood sugar levels, keeping them in that narrow range that your body necessitates and requires. And these hormones are like the yin and the yang of blood glucose maintenance. So how does insulin really work? So during digestion, foods that contain carbohydrates are eventually converted into glucose, and most of this glucose is sent into our bloodstream, and that causes a shift and an elevation in blood glucose levels. So this increase in blood glucose signals your pancreas to secrete or produce insulin. And the insulin tells the cells of our body to take in glucose from the bloodstream. And as the glucose moves into the cells, the blood glucose levels reduce or go down. Some cells use the glucose as energy, whereas other cells, such as the liver and muscles, act as a reservoir or a storage container for any excess glucose as a substance called glycogen. And our body uses glycogen for fuel between subsequent meals. So the opposing, the yang of the yin, is the glycagon, and that works to counterbalance the actions of insulin. So about 4 to 6 hours after we eat, the glucose levels in our bloodstream decrease. And what happens here is it triggers the pancreas to produce glycagon. And this hormone signals your liver and muscle cells to change the stored glycogen back into glucose. And these cells then release the glucose into the bloodstream so the other cells can use it for energy. And this whole feedback loop with insulin and glycagon is constantly cyclic and in motion. And it keeps our blood sugar levels from dropping too low, ensuring that the body has a steady supply of necessary energy. So glycogenolysis is the breakdown of the molecule glycogen into glucose. The olysis just means breaking down. So a simple sugar that the body uses to produce energy. So glycogen is really essentially stored energy in the form of long chains of glucose. And glycogenolysis takes place in the muscle and the liver cells when more energy needs to be produced. So simply put, the breakdown of glycogen to glucose. And that is stimulated by a drop in the level of blood glucose. And glycagon is secreted from the pancreas as a result of it, and which is trying to then elevate blood sugar levels. So it acts upon the liver to leave individual glucose molecules from the glycogen polymer. So as we said, glycogenolysis in the muscles makes glucose available for immediate energy transformation. We're going to look at new glucose being gluconeogenesis. And what gluconeogenesis is, it's the metabolic process by which an organism produces sugar, namely glucose, for catabolic reactions from non-carbohydrate precursors. So glucose is the only energy source used by the brain. Well, really without the exception of ketone bodies during severe times of fasting. So now what we're going to start looking at is metabolic conditions. And one of the metabolic conditions that we're going to look at is diabetes mellitus. So when we look at the UK's population group, there's about 3.7 million people diagnosed with diabetes mellitus. So the data from 2018 is indicating about 3.7, almost 4 million people are diagnosed with it. And this figure has actually tripled since 1996. There's actually an estimated extra 850,000 people were speculated to have type 2 diabetes mellitus, but actually they've actually went undiagnosed. So of the 3.7 million people it's diagnosed, approximately 10% have type 1 diabetes and the other 90% have type 2 diabetes. When we look at this globally, it's actually estimated that 346 million people have type 2 diabetes. And there's about 12.3 million people in the UK that are actually at risk of developing type 2 diabetes. And that's from research conducted from Diabetes UK in 2019. This is actually before the pandemic. So the main symptoms of diabetes as a result of high levels of blood glucose are feeling constantly thirsty and never got a satisfaction, so it's an intense thirst. Constantly with excessive urination and constantly feeling very tired and fatigued, as well as substantial weight loss. Another additional symptom is a sweet smell of breath. It's almost like when you eat a pear drop, it smells like that. So for type 2 diabetes, many people have the condition for years without actually realising this, because early symptoms tend to be general and their development is insidious. So it's important that we actually look at the short-term complications of diabetes. So few things to talk about is the hypoglycemia or hyperglycemia effect. So as sort of previously noted, one of the key difficulties which people with diabetes mellitus face, and particularly people with type 1 diabetes, is trying to regulate blood glucose levels within the fine limits normally naturally performed by the pancreas. So the acute effects of hypo and hyperglycemia are really about poor control of blood sugar levels, also increases the risk for many other complications associated with diabetes mellitus. So it's really important that even with good blood sugar control, there is strong evidence to show that those with diabetes are at risk, are an elevated risk of many associated pathologies. Another thing to really consider as well is hyperosmolia and hyperglycemic state. And that occurs in people with type 2 diabetes who are experiencing extremely high levels of blood glucose. And we're talking about times of greater than 40 millimoles per litre. And it often occurs due to the client being unable to medicate as normal due to illness and dehydration, and can take several weeks to manifest. And the common symptoms include significant thirst, excessive urination, feeling nausea, and confusion and loss of consciousness. Unlike in the case of type 1 diabetes, this state does not usually occur in the build-up of ketone bodies, as some insulin is still being produced, and as such an accumulation of ketones may not occur. So people with diabetes mellitus not only suffer the direct metabolic effects of inadequate controlled glucose metabolism, they also experience potential for diabetic coma and also accidentally overdosing in insulin. But they also suffer other knock-on consequences, and these consequences can be increased levels of blood glucose, and in long term, high levels of blood glucose actually results in significant damage to many structures of the body. And this includes microvascular disease such as eye disease, renal disease, and peripheral vascular disease of the fingers and toes. And this peripheral vascular disease, if not dealt with, can lead to skin damage, ulcers, infections, and potentially amputations to the peripherals. and there are over 120 diabetes-related leg, foot and toe amputations per week in England alone. When we look at cardiovascular disease, people with diabetes mellitus generally have poor serum lipoproteins. So the ratio of LDL-HDL levels, free fatty acid metabolisms, is depending on the efficient carbohydrate breakdown or catabolism. And therefore, in diabetes mellitus, higher levels of free circulatory fats are found together with deleterious cardiovascular consequences. And what these consequences include is atherosclerosis. So there's about a 5-fold increased risk of coronary heart disease and strokes as a result of having diabetes. And one of the reasons for this is that diabetes mellitus can change the histology of the blood vessels, and in particular damage to the endothelial linings, and that prevents the vessels from being able to dilate as efficiently as it previously did. In addition to this, the lining of the blood vessels actually may become thicker, and in turn it can actually impede blood flow and restrict the blood flow. So when we were talking about little blocks in eye vessels or anything, so this relates to just tiny little blood vessels such as the capillaries that are actually becoming damaged as a direct to diabetes. So damage to these blood vessels cause blood leakages called a hemorrhage, and which may be small and confined to the retina, or may actually extend forward into the jelly that fills the main cavity of the eyes. So it's extremely common amongst people with diabetes, with recent evidence demonstrating that it is the most frequent cause of blindness among adults between 20 and 74 years of age. So what Fong and colleagues in 2004 went on and stated was, during the first 2 decades of disease, nearly all patients with type 1 diabetes and over 60% of patients with type 2 diabetes have retinopathy. And the Wisconsin epidemiological study of diabetes, 3.6% of younger onset patients with type 1 diabetes and 1.6% of older onset, being type 2 diabetes, were legally blind. In the younger onset group, 86% of blindness was attributed to diabetes. So neuropathy is another condition and is a group of nervous disorders caused by diabetes. And what that means is there's damage to the nerves, in particular the myelin sheath, which facilitates the signals of the transmission of these nerve impulses. And this can manifest itself as sort of pain, numbness, or tingling, or even to an extent to complete loss of feeling. And there's roughly about 20 to 30% of all individuals with diabetes mellitus have some form of neuropathy. Although the exact cause of this condition is not fully understood, scientific researchers have shown that there is a relationship or a correlation between the length of the period an individual has been diabetic and the amount of neuropathy present. And this nerve damage is likely to be due to a number of elements, including peripheral vascular impairment, genetic predisposition, and also the most important one were lifestyle factors. So from an exercise prescription perspective, this is particularly relevant as individuals suffering from peripheral neuropathy in the feet can develop open sores and blisters. But they can actually be completely unaware of it due to the lack of feeling and sensation. And once these have become established, they can take actually a significant period to heal due to issues with poor circulation caused by the microvascular damage. So what is actually type 1 diabetes? So type 1 diabetes is an autoimmune disease that causes the body to actually attack the pancreatic beta cells that produce and store the insulin. And as a result, exogenous insulin is needed to compensate for the lack of endogenous insulin production. So you need insulin injected into the body externally because there's a lack of internal production of it. So even though type 1 diabetes was previously termed juvenile diabetes, type 1 diabetes can occur actually at any age. And the onset of type 1 diabetes is typically by the age of 30, but the greatest occurrence is actually during puberty. And the cause of the autoimmune condition isn't fully been established, but they have indicated that hereditary and environmental factors are correlated to higher incidence rates. So people with type 1 diabetes need endogenous insulin via the form of injections or actually an infusion pump to regulate blood glucose levels. Whereas a lack of insulin results in hyperglycemia if not treated, high blood sugar levels have a cascading effect of increasing urine production, and that ultimately increases the risk of dehydration, and if unchecked, ketoacidosis can actually occur. So when the body cannot take in the glucose from the blood into the cells, the body uses fats and proteins for metabolism. And in the case of fat as fuel, ketones as an acidic byproduct. And this accumulation of ketones actually alters and reduces the pH of the blood, resulting in ketone acidosis, with a number of common symptoms. And these can include, for example, excessive thirst, issues with constant needing to go to the toilet, constant urination. You may be vomiting and feel nauseous, abdominal pains, this fruity breath, pear drop breath. You may actually have had muscle confusion, and there may be changes of your breathing with dyspnea or shortness of breath, as well as muscle weaknesses. Often people who are unaware they have type 1 diabetes see the doctor or other healthcare professionals for symptoms related to ketoacidosis, and then are tested and diagnosed with type 1 diabetes. And these common tests include the HbA1c test, or a random or fasting blood glucose test, with the results of a glucose test compared against normative values. So an HbA1c test reveals that the mean or the average blood glucose levels of previous 2 to 3 months by measuring the percent of glucose that is attached to the blood's hemoglobin. So an HbA1c level of greater than 6.5% tested in 2 separate occasions suggests a diabetic condition, but not a distinction between type 1 and type 2 diabetes. So if the person is pregnant, however, an HbA1c test doesn't really provide any accurate results. So there is common medicines that is actually given to individuals with type 1 diabetes. And the most common one administered is that being insulin. And it's usually via a needle in a syringe and a cartridge, or a pre-filled pen, usually to the lower abdomen. Alternatively, it can be inhaled or delivered via an insulin pump. And note that the insulin pump cannot be delivered in pill form, and the particular type of insulin that is prescribed is based on the magnitude and degree and rate the person needs to affect their blood glucose levels. And you've got 4 varying types. You've got rapid acting insulin, and what that does, it reduces glucose levels within the first 15 minutes, but the effect lasts only for several hours. You've got something referred to as short acting insulin, and that requires about 30 minutes before becoming effective, but actually is continuous between 3 to 6 hours. You've got immediate insulin or intermediate insulin, and that does not reduce blood glucose levels until about 2 to 4 hours after administration, but is effective for up to 18 hours. And lastly, you've got the longer acting insulin, and that takes several hours to begin affecting glucose levels and keeps it level relatively for a 24-hour period. So what about the other diabetes mellitus being type 2 diabetes. So type 2 diabetes is a disease of insulin resistance. And normally in response to a mixed meal, blood glucose rises and pancreatic beta cells release insulin. And we know that that hormone facilitates the uptake of glucose into the muscle, fat and other cells. However, without adequate secretion and blood levels of insulin, or with impaired insulin actions or a combination of the both glucose increases to abnormal levels. And obesity is implicated because of the influence of the adipokines and the pro-inflammatory responses, as well as the direct inhibitory effect of obesity on insulin receptors in the muscle cells. So as insulin resistance progresses, pancreatic insulin-producing cells produce less insulin, resulting in insulin deficiency in type 2 diabetes. So insulin resistance coupled with other metabolic dysfunctions can also lead to dyslipidemia in several people and many people with type 2 diabetes. So insulin resistance is initially present before type 2 diabetes, and it can take up to 10 years for insulin resistance to progress to the diagnosis of type 2 diabetes. However, even though the clinical diagnosis of type 2 diabetes can be delayed long after the initial insulin resistance, the pathophysiology and the associated complications all can do negatively affect tissues during this time. It has been reported that over 75% of people with type 2 diabetes actually are among people who are obese and also sedentary adults. So individuals with a BMI greater than 35 have up to a 30 times greater increased risk of developing type 2 diabetes than people who've got a BMI below 23. And what we can see just at the lower half is just a table that represents the definitions and classifications of normal, impaired, and diabetes levels of fasting and random or postprandial blood glucose. So, what type of medication is actually given for individuals who have developed type 2 diabetes? So when we're looking at medical therapy for type 2 diabetes, it's targeted at improving the insulin resistance. And as a result, it reduces the liver secretion of glucose and stimulates pancreatic beta cells to secrete insulin. It should be noted that the initial treatment is always on or primarily focused on lifestyle change therapy. And this has been shown in multiple studies to possibly reverse type 2 diabetes. However, for several reasons, a large percentage of individuals with type 2 diabetes are prescribed medication. So, lastly, diet and nutrition and also exercise. Now, there has been evidence that aerobic exercise actually has profound benefits. And aerobic training can actually increase the mitochondria density, insulin sensitivity, oxidative enzymes, as well as the compliance and reactivity of blood vessels, lung function, immune function, as well as cardiac output. Now, research has indicated that moderate to high volumes of aerobic activity are actually correlated with substantially lower cardiovascular and overall mortality risks in both type 1 and type 2 diabetes clients. In type 1 clients, aerobic training increases respiratory fitness, decreases insulin resistance, and actually improves lipid levels and endothelial function. People with type 2 diabetes, what actually happens is regular aerobic training reduces A1C, triglycerides, blood pressure, and insulin resistance. And there's been reports that high-intensity interval training promotes rapid enhancement of skeletal muscle oxidative capacity, as well as insulin sensitivity and glycemic control. and it can be performed without deterioration of glycemic control in type 1 diabetes clients. When we look at the role of exercise and resistance exercise, diabetes is an independent risk factor for low muscular strength and accelerated decline in muscle strength and functional status. The purported health benefits for resistance training for all adults include improvements in muscle mass, body composition, strength, mental health, bone mineral density, insulin sensitivity, blood pressure, changing the lipid profiles, as well as improving cardiovascular functioning and health. The effect of resistance training on glycemic control in type 1 diabetes clients is actually unclear. However, it has been reported that resistance exercise can assist in minimizing risk of exercise-induced hypoglycemia in type 1 diabetes. When resistance and aerobic exercises are combined into one exercise session, performing resistance exercise first results in less hypoglycemia than when aerobic exercise is performed first. Resistance training benefits for individuals with type 2 diabetes include improvements with their insulin resistance, glycemic control, fat mass, blood pressure, and alterations to their lean body mass, as well as an improvement in muscular strength. And there's other benefits for other different types of physical activity. For example, flexibility and balance exercises are likely important for older adults with diabetes. So with this limited joint mobility, which is frequently presented, this results in part from the formation of being advanced glycation end products, which actually accumulates during normal aging and are accelerated by hyperglycemia. So stretching increases range of motion around joints and flexibility, but does not affect glycemic control. Balance training can reduce falls risk by improving balance and gait, even when peripheral neuropathy is present. Group exercise interventions, such as Tai Chi classes, actually have been reported to reduce falls by as much as 29%. We've also got the benefits of different styles of training, such as yoga and Tai Chi, even though they're less established. Within scientific research, there has been reports that yoga can actually promote improvements in glycemic control, lipid levels, and alter positively body composition in adults with type 2 diabetes. So there we have it. There's an overview of what actually diabetes is, what type 1 and type 2 diabetes is, and the role of the pancreas in trying to regulate blood sugar levels. So I hope you found this useful.